Preeti Sridhar, CEO Marivala Health Initiative. So, why do we look at the Mental Health Care Act for 2017? I think it's an important act that took away the gaps that the previous Lunacy Act had. This act talks about mental health as a right. It talks about a community based approach to implementation of programs. It acknowledges that people from marginalized backgrounds, women, children, people in mental health institutions, LGBTQI communities experience more stress or distress, and that there will be a need for specific programs to cater to the needs of these marginalized groups. The Act also talks about using the district mental health programs to deliver solutions and quality services and make services accessible to the last mile. So, in that sense, this is a very progressive act. This act also recognized that there is a need for suicide prevention strategy at the national level, um, and that psychiatrists and mental health professionals can be one way of delivering quality services, but there is also a community based approach. There's a psychosocial based approach that needs to be incorporated in program design by the government. So while we have the brilliant Mental Health Care Act, unfortunately, the implementation has been very weak of this act. And it stems from the fact that the budget allocation for the national mental health program is limited. And that limits by itself the amount of mental health professionals that each district can have. And therefore, on the ground, the DMHPs are unable to deliver the quality, accessible services to the people. So, the Mental Health Care Act of 2017 also mentioned that suicide is no longer a crime and that it has to be assumed that anybody who's attempting suicide may have a mental health issue. Now, while this is an important part of the Act, unfortunately, implementation has been lacking. There are still cases being filed against people who attempt suicide. So think about a situation where a person is in so much distress that they think about ending their life, and then they have a police case against it. So the mental health a person with mental health issue or with suicidal ideations or who has attempted suicide today is unable to access services because there will be a police case against them, in addition to the stigma that already exists against people with mental health issues and also people who attempt suicide. The other challenge that exists in India is that suicide is not talked about at all. There are myths about suicide. For example, people think that it's an individual issue. People also think that if you talk about suicide, the chances of person who is having a suicidal ideation resulting into an attempt is higher. There is also thinking that suicide is about a person being weak, not having enough resilience to manage it. But that's not true. People who think about suicide or have suicidal ideations want to have a conversation. It is important for us to have a conversation on suicide prevention that does not look at it from an individual lens but looks at it as a social issue. There is a need to talk about suicide from a public health lens. Just as we talk about any other health issues, there is a need to talk about it for mental health and there is a need to talk about suicide. If you look at death by suicides in India, it is a very different number than what is seen in Western countries. So, for example, in India, death by suicide is higher among young women, whereas in Western countries, it is the young male men who die by suicide. Similarly, when you look at suicide in India, in the 15 to 30 years of age group, it's the largest cause of death among youth. That's not true outside of India. So there is a need for us to recognize that the challenges that young people in India, that young women experience are different from the world. And we will need to have policies that incorporate and bring this understanding into foray and design programs that are more contextually relevant, culturally appropriate, and factor in the low resource setting of India. It is also important that we move away from this conversation of having psychiatrists or psychologists do interventions on suicide prevention. 50% of death by suicide in India cannot be attributable to mental illness. So there is a need to have a community-based approach to preventing suicide. There is a need to have a psychosocial approach to preventing suicide. I represent Mariwala Health Initiative. We are a grant-making, advocacy, and capacity building organization. Our journey started in 2016 when Harsh Mariwala, the chairman for Marico Industries, wanted to start another personal philanthropy. And his child, Raj, recommended that they work on mental health. As part of this thought, they did an inciting exercise where they spoke to mental health professionals, they spoke to academicians, they spoke to NGOs working in mental health, and even people who used mental health services to understand where is the gap in mental health. And they realized that whereas there are good, relevant, and scalable mental health programs in India, they were not getting funded. And that's why MHI decided to start its work on grant making. Today, we work with 33 partners across 28 states, providing mental health, providing grants to organizations that provide free, quality mental health services at the grassroots level. As our work started on grant making, we realized that there is a gap in understanding mental health from an advocacy angle in terms of stakeholders not fully understanding the psychosocial approach to mental health that MHI adopted. We therefore added advocacy to our component on work, which included advocacy with the state and central government, mental health professionals, as well as funders, because there is a need for more funding to come into mental health if we want to provide more services. As we started doing this advocacy, we also realized that the current psych disciplines, which are learnt by mental health professionals, do not understand unique stressors that certain marginalized communities experience. And therefore, in early 2019, we launched a flagship program called Queer Affirmative Counseling Practice. Till date, we have provided training to 450 mental health professionals in India and few of them in Southeast Asia, where we are teaching the mental health professionals how to look at mental health from a psychosocial lens, how to understand that people from marginalized backgrounds face unique stressors, and that there is a need for mental health professionals to incorporate this reality while providing individual counseling support.